Hi, good evening.
Hi.
How are you? I recognize a couple faces out there. I know Dr. Hall and I are really happy to be doing this for everybody tonight. It's really for you. So we have a bunch of slides prepared and we're going to talk about a couple different things, but we really want to make sure we have time at the end to answer questions and really maybe spend a little bit of time that sometimes in clinic we don't necessarily get to cover all the information that we'd like to convey to you guys about arthritis and joint replacement. So first I'm going to talk a little bit about just what the impact of arthritis is in the United States. So it's one of the leading causes of disability, and there are more than 66 million people who currently live with arthritis, and as many as 23 million probably have it and don't know they have it. I know Dr. Hall and I often see people who come into clinic and they say, well, my knee just started hurting last week, or I did this and I was playing pickleball, and oftentimes we sort of then are the people that are diagnosing them with arthritis that's probably been there for a while, but some event sort of set it off to where it has become symptomatic. It's certainly also a growing problem. So as the population continues to age, millions and millions more are going to continue to be impacted by arthritis. By 2030, we expect there to be about a 600% increase in the amount of total knee replacement and a 300% increase in the amount of total hip replacement performed in the US. And so this is just a graph based on sort of some of those projections and what we expect to see in the future. Arthritis, sort of at its core, is really just painful inflammation and stiffness of one or more joints. And so there are really four main kinds of arthritis. By far the most common is osteoarthritis. That's what we see most of the time in clinic and what most people here have. We also see quite a bit of post-traumatic arthritis. So regular osteoarthritis is just kind of wear and tear over time. Post-traumatic arthritis is after a previous trauma. So whether it was a fracture or ACL or ligament injury, and then down the line, it affects the mechanics of the joint that can cause wear and tear in a way where it wears out more earlier than it might otherwise have worn out. Inflammatory arthritis is also pretty common, so that's gout, psoriasis, rheumatoid arthritis, autoimmune diseases, and then probably the least common one we see, but we do still see some of, is septic arthritis. That is much less of a problem nowadays with the advent of vaccines and antibiotics, but that is where some sort of infection gets to a joint, and then that infection activates the immune system and the white blood cells, and that immune system activation actually causes destruction of the cartilage, and so it can be pretty catastrophic when that happens too. I often equate sort of arthritis, regardless of the category, to wear and tear. You know, no matter what it is, it's that the cartilage itself has worn out, and the simple analogy I often sort of talk about is the tread on a tire. And this is one of the things I often go back to also when people come in saying, well, how long have I had arthritis, or why did it just start hurting? And I kind of say, well, you can run your tire and it can start to go bald and you're doing fine, and it's going more bald and you're doing fine, and then all of a sudden it blows out. And then you got to replace the tires. And so in some ways, that's what sometimes happens with arthritis, is it's percolating and percolating and percolating, and then all of a sudden it becomes symptomatic. And so then we can talk about different things, sometimes surgery, but also things short of surgery in order to really manage those symptoms. So in terms of diagnosing arthritis, I got a couple examples up here. Is there a laser pointer on this? Oh, yeah, sweet. So this is a set of knee and hip x-rays, both sort of demonstrating what a normal x-ray looks like. So we'll start with the knee on the top. So the one with the blue arrows up here shows what a normal knee x-ray should look like, and a corresponding normal sort of cartoon demonstration of a knee. So we can't see the cartilage on an x-ray because there's no calcium in cartilage, and so we infer the health of the cartilage, whether it's a knee or a hip, by this space that we see here on the knee x-ray. And then as that space wears out and the cartilage goes away, then you can see how that space goes away. And so you can see similarly down here in the hip picture, that same sort of phenomenon occurring where that space between the ball and the socket wears out, and then it's bone on bone, and both of these pictures are really good examples for both a hip and a knee. And then the joint itself, if you actually look at it, goes from a nice, smooth, almost looks like fresh ice from an ice rink, a Zamboni's been driving on it, goes from that to like a cobblestone mess, is sort of what we end up seeing, where the cartilage is gone and it's really bone grinding on bone. And as you can imagine, that is pretty painful. So there are a lot of options before joint replacement. I know we're going to spend a bit of time here talking about joint replacement, robotics, outpatient joint replacement, but I think it's really important to talk about what can be done before joint replacement. So low impact activity is great. It's often tolerated by patients even with severely arthritic joints. I'm sometimes amazed at what people come in and tell me, you know, they're still biking 10 miles a day, 15 miles a day, but man, getting on that bike or getting off that bike or going up or down stairs, there's certain things that they really can't do, but when they're doing lower impact things like elliptical, swimming, biking, I threw in a picture here of larkspur. A lot of folks like sort of walking against the current in here, which is great before and after surgery to sort of help. Yeah, it's super popular with a lot of my folks. But so low impact stuff is great. It doesn't put as much force across the joint, and so for different people, that means kind of modifying their activity, things that they used to do quite a bit of, maybe they sort of modify to not do quite as much or doing a little bit of a different way so that they can have less pain. Physical therapy can also be really, really helpful for folks. So this improves joint mobility and motion. It helps to strengthen the muscles around the hip or the knee. And this can actually alleviate some of the stresses across the worn out joint so that maybe there's not quite as much force through that joint when you're doing certain activities. And then it can also help avoid deconditioning, which can be helpful if and when joint replacement becomes necessary to facilitate a smoother recovery if you still have some of that good muscle strength and tone. Sometimes it's a little bit of a catch-22 where we send folks to physical therapy and it actually seems to make things worse. And that's partly because maybe it's a sign that they need to try a couple other things or that the joint is arthritic enough that they need to maybe think about some other options. Weight loss, I mean, that kind of is a pretty simple one. One of the numbers I often quote is this one down here at the bottom, that especially for the knee, if you lose weight, it puts a lot less force across the knee joint. And in terms of the mechanics of the knee and how it multiplies those forces across the knee, if you lose 1 pound of weight, it results in 4 pounds of less force across the knee. So 1 in 4, it seems like 10 pounds, that's 40 pounds less force across the knee. So even though losing 10 pounds may not seem like a whole lot, it can make patients feel a whole heck of a lot better. The hip isn't quite as dramatic, but similar effects can be manifested there as well. Bracing is also another great non-surgical treatment option. It can provide stability to increase patients' activity tolerance. Unloader braces are probably the most frequent ones that Dr. Hall and I use in clinic. They specifically unload or open up an area of the knee that is more arthritic. So if you look, this is a medial unloader brace example. So the idea is the brace itself creates force to open up that space. It's not recreating the cartilage, but you can kind of see how you go from an arthritic knee to a knee that looks healthy, but really it's just taking the pressure off of the inside part of that knee. And so I've got several folks who, they wear a brace like this when they're out golfing or hiking, and it is quite helpful just to take some pressure off of that one part of the knee that's more arthritic. For people who have arthritis that's more through the entire knee, these braces aren't necessarily quite as helpful. But if you come in and you have symptoms that are, just on the inside part of your knee, and you've got an x-ray that looks like this, a brace is potentially a good option for you. Oral medications, I think, are another great adjunct. A lot of folks are taking, by the time they come to see us, Tylenol, some sort of other anti-inflammatory like meloxicam, Celebrex, or Aleve. Pain medications, I think a lot of us are pretty reluctant given sort of the whole climate, what we've learned about opioids and everything in terms of trying to cut down on those both before and after surgery. Tramadol is one that the American Academy of Orthopedic Surgeons sort of has some intermediate recommendations on. It's not quite as strong as some of the other ones. It's sort of one that I will sometimes consider in folks who the arthritis is severe and we already are trying to get them on a schedule for surgery, but we need something to try and make them a little more comfortable, but that's usually not something I want people on long term. I get a lot of questions about glucosamine, chondroitin, omega-3s, turmeric, other supplements. I think all these things are great. I think some of them have stronger literature to support them than others. None of them are really harmful. I think that anything that's anti-inflammatory, whether it's a more natural supplement or one of these medications, is going to have a huge impact on the pain, because a lot of the pain from arthritis is from inflammation. So when the joint wears out, it's that body's inflammatory response that is what's causing a lot of that pain. And so however you manage that inflammation can be quite helpful. Injections are another common non-surgical option. So for knees, we often just do this injection in clinic based on the anatomic landmarks. We sort of feel where the kneecap is and some of the tendons are, and we are able to get the medicine in there. We can also sometimes do this under x-ray or ultrasound if there are certain things that make an injection a little bit harder to do based on the landmarks. Hip injections are often done under x-ray. Even though the hip joint is not necessarily that much deeper, it's just a little bit harder to make sure that we get the medicine into the right place. And so we have our partners, the physiatrists over at the center, who do this under x-ray guidance, and they make sure that they get the medicine into the right place. So you can actually see this is a picture. It doesn't work for everyone. I can chat a little bit more about that too later on. But this is showing the needle and then the dye injection there into the hip joint. Steroids are usually what we inject. We can also sometimes do visco supplementation. You've probably heard about the gel, the rooster comb, there's a whole bunch of different names out there. There's a whole bunch of different brands. And then also PRP, or plasma-rich protein, or stem cells. If you sort of look at the literature that's out there, steroids probably have the most support. They do definitely provide relief in terms of relieving the inflammation. The visco supplementation, or the gel injections, if you look at the studies that are out there, they are at best the same as steroids, but a lot of the studies, they probably are not quite as beneficial. That said, I've had a lot of patients where we try the steroids and they don't work, and then we try the gel and the gel provides relief. And so anecdotally, I think they definitely can be helpful. The idea with the gel injections is that they have hyaluronic acid and some other compounds that are the biomolecules that are in cartilage. And so by trying to put those into the joint and increase sort of some lubrication in the joint, that should hopefully treat the symptoms from arthritis. Again, they're not regenerating the cartilage. That's sort of the hope of some of the PRP stem cell injections. I think for a lot of folks, once you get to the point where it's more severe arthritis, these things are not going to provide very much relief. Again, there's some evidence that maybe they can help with inflammation. A lot of the insurance companies don't cover them, partly because of the data behind them, and so a lot of people will offer them, but you got to pay cash, and it's not cheap to get those done.
Where does cortisone fit on this?
Cortisone's under the steroid injections here.
It's what?
It's under the steroids.
It is.
Mm-hmm.
I'm
Yeah.
sorry, I'm not
No, that's okay.
ask questions.
No, that's okay. And so injections and various different injections, I think, can be super helpful at various times in the treatment course, and sometimes as an adjunct to the bracing and the physical therapy and other medications. Assisted devices, so cane or walker, I mean, by the time you start to notice that you need to use this more consistently, again, it may be a sign that we need to talk about some of the other options short of surgery, basically. This takes force off the arthritic joint, similar to how losing weight does. This can distribute the weight through the rest of the body, basically. Most people, when they use a cane, they want to use it on the affected side. Counterintuitively, you're supposed to actually use it on the unaffected side, and so that sometimes is helpful for folks too. Arthroscopic surgery is sort of the last thing I wanted to talk about here, short of joint replacement. So I know this is surgery, but it's obviously not joint replacement surgery, and so we get a lot of questions about this, and if you went back maybe 5 or 10 years, we were doing a lot more of this. The idea is that we can treat some of the mechanical symptoms. When the joint starts to look like this on the inside, the meniscus is right here, and it's quite frayed, and the cartilage is up here and also looks kind of frayed, and so we can go in and sort of clean things up, address some of the locking, catching symptoms, but there's some concern that this may actually advance arthritic progression, because all these things, you take out a little bit of meniscus here, a little cartilage there, and it can cause some point loading across the remaining cartilage that may accelerate things. If you look at some of the studies that have come out in the last 5 or so years, specifically looking at some various different things. So one was looking at specifically exercise therapy versus arthroscopic partial meniscectomy. So this basically means people went for physical therapy, or they had part of their meniscus taken out. There was no difference in follow-up at 2 years, and the people who just did therapy actually had more strength. And so I often sort of refer to this kind of article, and then the last one here, which shows that the average time between knee arthroscopy and knee replacement is about 2 years. So it's often sometimes sort of a pit stop on the way towards the next surgery. And so you go through a surgery, you go through recovery. I often recommend that we sort of try the bracing, the injections, the medications, because we know we're going to most likely end up at a replacement. And if we can avoid the surgery in the first place, that can be helpful. The other thing, which I didn't put up here, but there is some suggestion that perhaps patients who have previously had a knee arthroscopy who then have a knee replacement are not as satisfied with their knee replacement after the knee replacement. So there's a lot more stuff probably buried in those studies, but it's something to sort of keep in mind too. I think sometimes people understandably want a smaller surgery, but hopefully with some of the technologies and things that you'll hear about tonight, even though it's still very much a big surgery, we've come a long way in terms of how we're able to do it and get people home in many cases the same day. So one of the most common questions I get in clinic is, okay, so you told me all this stuff I can do, and you told me about joint replacement. What should I do? And my answer always is some form of coming down to this discussion about quality of life. And so I really pay attention to what people are telling me in terms of what they want to do, what they can't do, what they used to do, and how much what they're telling me and their arthritic symptoms seem to be affecting their quality of life. And there often comes a point where their quality of life is suffering enough that then it's worth taking on the risks of something like surgery. So that's when pain you have every day stops you from doing activities that you enjoy. I don't think this is Central Oregon, but it very well could be. So obviously hiking, a lot of pickleballing here, lots of, I did a knee replacement today on an active skier who skied like 50 days this season, but his knee was horribly arthritic. And so he's able to do some of the stuff that he wanted to do, but it was having a negative impact on how he felt when he was doing it. It's really a decision that factors in non-operative management, so a lot of those things that I spoke about before, and when the time is right for you and your family. And really, it's about quality of life. Joint replacement is about quality of life. And that's why I think Dr. Hall and I enjoy what we do so much, is it's really gratifying when we have patients come back in and they say, I skied 25 days this year on my new hip. It's awesome. Thank you so much. And that is really what makes it worthwhile. And I think just understanding all of the steps before that, I think can sometimes be beneficial for folks too.
Thanks, Dr. King. I'm James Hall. I know a lot of faces here. It's good to be back in person. The last couple of years we had to do things virtually, and that's never the same because we get to see your faces and your reactions to what we have to say. But like Dr. King said, the most important thing is quality of life nowadays. It used to be 20 years ago, if you could walk 5 blocks, you couldn't get a joint replacement. But things have changed, and that's what we're here to talk to you about, some of the different changes. So the topic of this is what's hot, what's new, what's not, and what's hot. And we're going to briefly kind of touch on a lot of things. And we're going to talk more openly about outpatient surgery, robotic surgery, and things that we're doing now. So what's new? Newer than in the last maybe 20 years, mostly our materials that we have, and that we're encouraging people to stay more active after joint replacements. Years ago, it was if you didn't come in with a cane, you didn't have surgery, you came in with a cane, usually you walked out with a cane and you stayed with a cane forever. But things have changed. Some of the history, and this is a busy slide, but it just tells us what has gone on through the evolution of orthopedic surgery and joint replacement. It wasn't until probably the 1960s that Sir John Charnley in England really started to develop better hips that were meant for sedentary lifestyle, people that weren't walking, that could just get up and now interact. So they weren't meant for a lot of activity. And those kind of mentalities stayed with us from the 1960s to about the 1980s when things really turned the corner. We started dealing with what we call modular components, components that were interchangeable, that we could remove parts of if they did fail and not have to remove the whole joint replacement. So that really changed how things were. And then mostly in hips, the plastic insert that we'll see, those went through a whole evolution of engineering to where we are today, where we virtually don't see much wear. Through the 1990s, we started working with ceramics, ceramic balls in joint replacements, not so much in knees, but in hips. And now, alternate bearings are the key. And it's usually, at this point, ceramic with a plastic or a high molecular weight polyethylene, or a metal with a high molecular weight polyethylene. So the studies between the newer plastics, or what we call cross-linked poly, are virtually light years ahead of where they were even 15, 20 years ago. Better materials. So back in the 60s, 70s, stainless steel was a big utilizer in joint replacements. Stainless steel is hard and our bones are soft. So as we started working with titanium alloys, those are softer metals and they kind of bend with your bone. You can't see the bend, but the bend is there. So they're not as rigid, and the hope is that they last longer, and they did. Articulations, as we talked about, is the key, the bearing surface in hips and knees. This is an example of a hip replacement, and the plastic inserts. So it's for the most part, a metal or ceramic, plastic, metal articulation sandwich that we're utilizing. Problems, as we talked about, the plastic wear. Back probably 20 years ago, I would say, things really changed, but we used to see x-rays after about 10, 15 years of a joint replacement being in place, and you start to see where there's plastic wear. And the only way to see that on an x-ray is where you no longer see the ball centrally located in this cup. As you can see, it's a little higher in this articulation here. It should look similar to this, where the ball is just in the center. We also see a lot of bony destruction with the early wear in plastics, and that's why things failed. You'd get loosening of the bone, loosening of the components, therefore the implant causes pain and fails. And we did see that for after about 10, 15 years. Bearing surfaces, and now we're typically dealing with hips because that's been the problem in the past, but we have way better bearing surfaces now. We have mostly ceramic, which isn't a very brittle or fragile ceramic. It's pretty highly durable. Ironically, all the ceramic balls that we utilize in the world come from one factory in Germany, so it's kind of interesting. And then there's oxinium, which is also a different type. It's not quite metal, it's not quite ceramic. So all these bearing surfaces are wonderful. They're made by different companies. This is an example. We don't use this as much on the end. Whoops. This one here on the end. It's a ceramic on ceramic bearing surface. It's a wonderful hip replacement that lasted for years and years. However, there's about a 5% of population that had a squeak with it, and the squeak was audible for everyone. And it's like going back years. When they used Teflon hips years ago, they squeaked, and now we came back full circle. So if you can imagine, that's not always pleasant. But all jokes aside, yes, in those, a lot of times it was a lubrication problem, and taking fish oil or other supplements helped. New materials in knee replacement. This is actually an example of a knee replacement that Dr. King and I use in certain individuals that might have a metal allergy. It's always important, if you do have a known metal allergy, meaning you can't wear jewelry, can't wear watches, you can't tolerate anything but gold, that's important to let us know, because usually that means you have a nickel allergy. Not all the time, but a lot of time. When you have a nickel allergy, particularly for knees, we do like to use this particular implant, which doesn't have as much nickel. They all have a very slight amount of alloy combination of metals. I just want to be normal again, is what people say. And I think Dr. King and I both say, well, what's normal for you? You know, what's your activity level? And we have to take that into consideration. Being Olympic level athlete probably isn't a smart choice or something that's going to happen. Even professional athletes sometimes can get away with a number of years, but it's usually not something that's sustainable for a long time. Here, sports, summer sports, down the list. I'm sure I missed a lot of them, but lots of our patients want to interact and continue hiking, swimming, pickleball, kiteboarding now, wakeboarding, swimming, paddling, surfing. And these are all activities that 20 years ago, if you said, hey, I'm going to go out and water ski or surf with my joint replacement, we'd probably look at you funny. Now we don't as much. So we like to see you out and about. Winter sports, downhill skiing, skate skiing, cross-country skiing, snowboarding, snowshoeing. These are all things, and I always say, you know, depending on your level of activity beforehand, it's not time to, as I say, I can say it now, rekindle the glory days. You don't want to do something that you don't or haven't done in the past. It's just probably not a great idea. Discouraged activities, some of them are obvious, but high impact repetitive activities will potentially do some long-term damage to your implants. And that's taking up running again, jogging, high impact aerobics even on a repetitive aggressive basis. Zumba's okay though. Concerning occupations, yes, there are, we still do joint replacements in these folks, but there are some limitations in terms of high impact falls or twists and pulls. So that's always something that it's important to let us know what you do. Now, what can go wrong with a joint replacement if you do different activities? Well, for the most part, with hips, it could be dislocation. We're not seeing that quite as much. Revision surgeries have about a 3% risk of dislocations. I think Dr. King and I could say probably less than 1% now for dislocations in hip replacements. Component wear, not quite as much that we're seeing now, which is really good. Fracture, anytime you have a bad injury around a joint replacement, that's a horrendous thing. Usually the joint replacement lasts, and it's the bone around your joint replacement that doesn't. These are all fixable potentially, but just not great things. So how long does a joint replacement this day and age last? This is probably a little dated, this slide. I think a lot of us, and Dr. King can nod at me, I think we say probably 20 plus years now with our modern day implants. That's without abusing, you know, and running and jogging and jumping. Funny story, when I first got here, and I'm dating myself, 2005, I had two gentlemen, one of them that's not with us anymore, that came in and said, hey, we play softball. And I'm like, yeah, that's fine, just don't slide. And then they're like, we won't slide. So I go out to a game, this is years later, and they're sliding and they're just having fun. And they did well, but you just have to understand that that's not something that you want to see as a surgeon, but people do it, and it worked out for them, and for 20 years they had great fun. Now, what's not in joint replacement? This is short. A lot of this is dated, so we don't have these problems. One thing that was very popular for probably about 5-10 years ago was patient-specific implants. That's where surgeons would say, hey, I got a custom implant for you. We're going to take it to the factory and make a mold of your bone, and it's going to fit you perfectly. We didn't find that was routinely a great type of joint replacement. Meaning it didn't always last as long as we had anticipated. So it's not quite as popular. These are custom implant or custom cutting jigs that we utilize that were meant just for this individual. So it was individualized, and it didn't always work out well. A lot of claims with customized blocks in terms of it was a big marketing maneuver because everybody wants something that's custom just for them, not off the shelf. The good news is that our off-the-shelf components are state-of-the-art, and we have hundreds of sizes, so we always match you up pretty good. So that's good. What's not? Lawsuits you read about anywhere in any literature, TV, online, about, you know, if you've had a joint replacement, contact this number. It's a very few number of individuals that have had recalled components. Usually the surgeon will know if it's something recalled, but in the course of the last 20 years, there's been maybe a handful of components that have truly been recalled. And a lot of us understand why they've been recalled and never used them here in town. Some concerning implants. When you have a lot of moving parts that are metal bearing, they might seem alluring to a surgeon to utilize because there's a lot of variation that you can do to customize. But we find that too many moving parts, not a good idea. Metal on metal bearing, we utilized that quite a bit about 5-10 years ago. We've learned over the years that that causes more wear than we'd liked. And so now the ceramic on plastic is probably the most common bearing. This is the squeaking joint that we talked about. An outstanding joint, though. This was in high caliber athletes and very active people, but only a small population did have these problems. So what's hot? Right now, what's hot? Dr. King and I are both doing minimal invasive surgery. We used to call it minimally invasive. Now we call it minimal incision. Minimally invasive got a bad name about 10 years ago because surgeons were not being able to see and injuring and having bad outcomes. Now, with smaller incisions, less dissection, we're actually able to really decrease the overall insult to the body, which is really nice. And then computer and robotics surgery, which we'll talk about a little later, as well as outpatient surgery. Just real quick, this is our computer on the right side. This was 2000s. We started probably 2005, 6. This is our robotic arm on the left that we utilize to this day. All right, Dr. King, you're up. Thanks.
All right, I'm going to talk a little bit about outpatient joint replacement and then kick it back to Dr. Hall. And then I know we're probably talking a little bit more than we intended, so we're going to try and make sure we get time for questions at the end. But this doesn't, there's not a ton for me to talk about here. So 2020, obviously COVID, that set things back in terms of being able to do surgery in general, but also at the hospital. And then 2022, 23, you know, it seems like we get over one thing and then we're finding ourselves with the next problem. So obviously COVID had a huge impact on elective surgery. And this was a study out of the Bone and Joint Journal that at that time, this is about 1.5 years, 2 years old actually, was saying that there was a projected backlog of more than 1 million elective orthopedic spine and joint surgeries that could take up to 2 years to work through. I can tell you Dr. Hall and I are still working through things where patients come into clinic and they're like, well, I don't know, I was doing okay. And then COVID happened and now I'm coming to see you. Like, well, I wish you'd been here a couple years ago because, you know, it's a lot worse than it was back then. Now it's a little more urgent that we get it done. So that had one impact. Obviously, the nurses, it looks like, are probably going to be on strike coming up, and so that may impact that, hopefully, at least for a short period, but we just can't catch a break. So partly because of COVID, but also sort of preceding that, the team over at the center, and specifically Cascade Surgery Center, really started to see some of the benefits of outpatient surgery, specifically outpatient joint replacement. And so I can take no credit for the founding of this program in 2016. I was still in medical school, but Dr. Hall and several of the other surgeons here really helped drive this to the point where last year we did over 900 joint replacements at our surgery center. This has been driven primarily by a desire to help optimize care for patients. So it keeps you out of the hospital. It emphasizes a recovery after surgery that's a little bit more rapid, but also tries to make it a little bit less painful, hopefully, for you. We have employed multimodal pain pathways, so everybody pretty much nowadays gets some sort of nerve block with a whole host of different medications that help during and after surgery. This is a huge cost savings to the healthcare system. I know we're in the middle of this debt ceiling fight, and Medicare spending is always seems like on the chopping block, but this is a way that we can actually help save the healthcare system dollars by delivering high quality care out of the hospital. And this was all driven really by an emphasis on patient safety. So not only do we want to do it and do it well, but we wanted it to be safe for patients. So there's been a lot of research looking at the safety and benefits of outpatient joint replacement. And so this is a study, the first one is here out of the Rothman Institute in Philadelphia. And they found that outpatient joint replacement did not increase the rate of complications after joint replacement surgery. And then this second paper is by one of the several folks out of Rush, including one of my co-fellows. And they found that patients were more satisfied when they had outpatient surgery rather than when they had it at the hospital. And then this is also making its way into the lay press. The New York Times had an article, I think about a year ago now, saying maybe the best place to recover after a joint replacement is actually at home. So just to sort of toot our own horn a little bit, our ambulatory surgery center, Cascades Surgery Center, is a top performing ASC, or ambulatory surgery center. Becker's, which is a national sort of publication that looks at a whole bunch of different things in healthcare, listed the top 20 ASCs that performed the most knee replacements in the United States in 2022, and our little ASC performed 1.1% of those surgeries here in Bend, so we're number 4 on the list, and so it's pretty cool. We're doing a lot of it, and I think doing a really good job of it, and I think this just highlights that in some ways they were a little bit ahead of the curve, and I think COVID and a lot of that kind of accelerated it, and things were sort of primed to do really well, but we're really, really proud of this too. So in terms of outpatient surgery for you, what does it take to get ready for it? The biggest thing is we always want to make sure that, and one of the requirements is that you have a visit with your primary care doctor or the St. Charles preoperative clinic to make sure that you're in good health and you're healthy enough for surgery and that it's going to be safe. Some exclusions specifically for outpatient surgery are a BMI, body mass index more than 40, heart failure, having a defibrillator, uncontrolled diabetes, if you're a current smoker, or you have untreated sleep apnea. So I threw up here the screening questionnaire. So when Dr. Hall and I see folks in clinic and we say, hey, we think you'd be a great candidate, then we start to go forward with the process. They see their primary care doctor. They get a call from our anesthesia team at the surgery center. And one of the questionnaires they get over the phone is a stop bang questionnaire, which is a really simple screening questionnaire for sleep apnea. And this is probably one of the biggest holdups for people who are otherwise super healthy or ready for surgery, but they have sleep apnea. And so our biggest concern is that if you have untreated sleep apnea and you throw on it anesthesia and pain medications, and you go home that first night of surgery, that you could have an apneic event where you basically stop breathing that could have pretty profound consequences. And so that's why we're so strict about this. So for some people who maybe think they might have it or are thinking about joint replacement, if you get set up with the sleep clinic and maybe get a CPAP, that can take one of the things off the list of things that might keep you from being able to have your surgery as an outpatient. So the other thing that we're really want folks to do is identify their coach. And so this is someone who's available to assist you for 24 hours a day the first 7 days after surgery. A lot of folks ask, well, what do they need to do? Do they need to be a nurse? It's not really that. It's mostly someone who can help. You're going to be worn out from surgery. You want someone that can maybe help prepare some of your meals, help keep the medications, keep track of them. You're taking different things at different times. And so having someone who can kind of help you with some of that stuff can be super helpful. Dental work is also something that's really important. We worry a lot about infection when it comes to joint replacement. And if you have a lot of pending dental work, we often want folks to get that done before surgery, in part because we want you to wait at least 90 days after surgery before you get any dental work done because of the risk of infection going from that dental area to the joint replacement. One of the other things you can do, and I put the URL up here, and it's pretty easy to find actually if you go to our website too, but the total joints class, which is something that Dr. Hall, Dr. Ballum, Dr. Lilly, and I put together. It's something that the hospital used to put on for patients who were going to have joint replacement surgery, where they had some nurses that went through what to expect before surgery, the day of surgery, after surgery, common questions, different things to sort of consider. And so we sort of, once the hospital stopped doing that, due to some budget cuts, then we decided to put on ourselves. And so there's a whole series of videos. I think it's, almost 45 minutes of videos, maybe 30 minutes of videos. Each one is only about 5 minutes, and it's broken up by different times related to surgery. It's really nice for folks because they can watch just the part they want to watch and get their questions answered, and which can be really nice. And some people learn better with video, so that can be super nice for folks too. And I'm going to toss it back to Dr. Hall to talk a little bit more about robotics, and then we'll answer some questions.
Thanks. All right, so robotic surgery and computer surgery, as I stated before, computers probably early 2000s that we started using in surgery. And we really were pioneers here in Bend, which is really nice. My former partner, Dr. Bueller, was a big proponent of that. But robotics, the evolution, as we talked about, 2000s, about when we started using computers readily in surgery. And now in the last probably 7 years, robotic-assisted surgery has really taken off in orthopedics. Now, we're a little behind the other services, such as general surgery, GYN surgery. They have what's called the Da Vinci robot, which is a real robot. We have kind of a robot, but it's great. These are just to show you some of the tools. We have some really cool tools. These are older tools that we utilize, which involve long rods that go down the center of the bone for alignment. Those in themselves can cause some problems. We didn't see it readily back in the early days when we used them. Some surgeons still use them readily, and there's nothing wrong with them. They're very accurate to this day. Robotic surgery started with computer-assisted. Basically, in computer-assisted, we're inputting the data of your knee into the computer at the time of surgery. And we're utilizing that data to make predictions for cuts where we need to make the bone cuts to get you a nice balanced joint. Robotic assistance is the next step above that, as we'd like to say. Once again, it's not like a Da Vinci robot that the general surgeons and other surgeons have, where they can sit in the corner and play with joysticks and the robot does all their things. Ours is still an interactive. We still control the arm of the robot, so we're still doing the surgery. Robotic assisted surgery is quite neat. We do get what's a limited CAT scan of your extremity, knee or hip beforehand. And what we do is we do the surgical planning on computers before the surgery actually occurs. We can tweak it at the time of surgery, and then that data gets inputted into our computer in surgery, and we can start what we call balancing the knee, changing component position to make your knee a little more customized, as we say, within limits. It does very slightly probably shorten your overall surgical time, because we're doing some of the planning ahead of time, which is nice. This is just an example of what it would look like in surgery on the left-hand side. We utilize hoods, which we call these body suits, to decrease the overall air contamination in the room. We have computer screens, and this is an example of the robotic arm that we utilize, and gives us a little more accuracy. This is a close-up of it for a knee replacement. This is what we see on the screen. It's a little more complex than painting by numbers, but that's something. So this is an example of hips. There's new software that might be a little more alluring to us. The first version of this, as you can imagine, with any technology, was basic. As we move forward, we get updates probably every 3 years, where we can do a little bit more planning and hopefully make your surgery a little more accurate. Even though surgeries that weren't done robotically are extremely accurate, we're just trying to get to the next level. For hips, we have cool attachments to the robot that we can add to do kind of the work that we did before, but we're still controlling the robot. The advantage, as we say, it doesn't make you bigger, stronger, better, stronger, faster, quicker. It does allow us to get things hopefully a little more accurately, save you a little time in surgery, and stay up to date with modern day technology. So here in town, we have 3 robots, 2 at the Cascades Surgical Center, 1 at the hospital that we utilize throughout the community. So we're probably a little ahead of a lot of communities our size with robotic and computer surgery, which is nice.